everyone, to today's webinar, How to Create a Personalized Connected Patient Experience. I'm Mariah Taylor with Becker's Hospital Review. On behalf of Becker's Healthcare, welcome and thanks for joining us today. Before we begin, I'm going to walk you through a few quick housekeeping instructions. First, we will begin today's webinar with a presentation, and we'll have the time at the end for a Q&A session. If you have any questions throughout the webinar, you can type those into the Q&A box you see on your screen. We will also have a series of poll questions during today's webinar. If you get to the poll, the questions will pop up in your slides box, and you can submit your answer directly on the screen. Thanks in advance for participating. Today's session is being recorded and will be available after the event. You can use the same link you used to log in to today's webinar to access that recording. Lastly, if at any time you're having trouble with your audio or video, please try to refresh your browser first. But if that doesn't fix the problem, go ahead and submit any technical questions in the QA box, and we will do the best we can to help you. At this time, it's my pleasure to introduce today's presenter, Casey Williams. Casey Williams is the Senior Vice President of Patient Engagement and Payment Applications at RevSpring. He has over 20 years of experience in developing intelligent patient communications and payment applications that build a strategic relationship with clients and their partners. He has held various leadership positions within healthcare trade organizations, such as HFMA, AAHAM, and COPAM. Casey's knowledge of patient engagement strategies, including modifying patient behavior and self-service optimization, has made him a go-to speaker for HFMA, Healthcare Finance Institute, and Litmos Healthcare Division, formerly Bridgefront, to name just a few. He's the co-author of Reinventing Revenue Cycle Management, Delivering Next-Level Patient Experiences, and has been published here in Becker's Hospital Review and Executive Insight magazine. Now, without further ado, I'm going to turn it over to Casey to begin the presentation.
Well, thank you for that. I appreciate the introduction, and it's always great to partner with Becker's and providing education and just really an overview around how the patient experience is continuing to be such a driver within healthcare as a whole. And we're going to go through the reasons why a personalized connected experience is meaningful in regards to how your individual health system is interacting with patients and what that process is in terms of leaving that impression and how that impression then radiates in terms of how the patient thinks about the healthcare system as a whole. When you kind of think about patient experiences as kind of an outcome-based measure, you know, one of the things that I think as an industry, we put, at least in my opinion, have put too much focus in and around the experience on the clinical side, and we have not really, as an industry, focused in on the experience from a revenue cycle side or a non-clinical environment, meaning that, you know, what is the post-outcome interaction, or what is the pre-outcome interaction that we have with patients that is outside of that clinical experience. And really, when we stop and think about kind of what the landscape of healthcare is now, and the leaders that are on this call and listening to this education, is the stress levels is I like to call it, have never been higher. You know, I remember when I first entered the revenue cycle industry, you know, 20 some years ago, you used to be able to make a call to someone that you had been interacting with, and even a longtime client, and within, you know, the day or so, you would get a call back. And you know, now you can have a 20-year relationship with a revenue cycle leader, and it's so busy in terms of just the demands that are on each and every one of you on a daily basis, whether that is bad debt, whether it's patient revenues and yields being down, whether it's deferred care expectations and out-of-pocket expenses that your patients are now dealing with, and you know, the loyalty from a patient experience is down. These are things that you are now having to focus in on, that's in addition to the normal day job that you had prior. And then you look at, you know, just the experiences that we had with COVID and inflation and the overall labor and supply markets that, you know, is driving those individual costs up, which then affects the overall cost to collect. And if that wasn't enough, then you have extensive turnover, usually within your staffing environments, of those, you know, legacy employees that had kind of directive of individual initiatives, or at least had the institutional knowledge that was able to help you institute, these individual initiatives and or concepts with it all. But yet, as you're dealing with that, the expectations from a health system or from a clinical care facility has not or is not going away. And the concepts of new initiatives and the expectations of delivering it fast or to do it fast continue to add to that stress factors. And the way that I measure that is just the timeliness in terms of meeting up for a lunch or answering a phone call within that. And you all just do not have the time that we used to have within this industry, and it's because of all these pressures that you all are under because of the individual environments have changed. One of those changes that has really driven how we interact from an experience perspective, meaning like how are we thinking about our interactions or our touches within patients, is loyalty. And you think about that in terms of what drives loyalty. You can kind of compartmentalize this within a couple of different areas, at least in the way that we think about this. The first is usually care quality, meaning do we have good teamwork? Are we providing courtesy and respectful interactions to the individual and patient? And that experience can differentiate the brand when it's done exceptionally well. I want to make sure, though, you're listening to this, because if we're not doing it well, it can also differentiate your brand in a negative way. I don't believe that this has a just kind of a benign type of setting. I think these impressions, as the patients are interacting within your staff and within your flows, and quite frankly, within your technology, that it is leaving a positive and or a negative impression. I don't think that they're just walking in and solely focused in on the clinical outcome. So when you think about that in terms of workforce engagement, do we have a good patient-provider communication? Oftentimes we get in to see physicians, and again, this is where I think this experience concept really comes from, just on the clinical side. I can remember when my mom was going through end-of-life care, and she was doing some clinical trials, trying to be a benefit for the community moving forward. And there was this one physician at a large health system that we were interacting with, and I remember he just had such horrible bedside manner. To the point where I had courage enough to kind of interact with him and say, listen, man, here's the situation that we're going through. The very least expectation that we have in this setting is that you extend some sort of care within this environment that is beyond the clinical side, meaning we need you to have a little bit of empathy within this environment. And he said something that really changed my interaction within people that have different gifts and different blessings in life. And I remember to this day, he looked at me and said, Casey, I care about your mother, but the Lord has blessed me with remarkable skills from a physician standpoint. He has not blessed me with good bedside manners. And I just remember that it did not excuse his interaction with me, but it really did say to just the grace that we need to have with one another, that we do have strengths and we do have weaknesses, and how we interact within those matters greatly. But here's what I'm going to leave you with. It's now 20 years or 15 years after that experience, and only because of that conversation did I think about that in maybe a different manner. But our experience was negative because of that interaction. Was it because the clinical outcome was any different? No. Was it because of the technology that I was engaging with? No. It was simply around, how did this individual engage and respond and interact with the patient within that care setting? And so I just want to make sure that you're taking at least that from this meeting today, that just the simple workforce engagement, meaning everybody that is reporting up to you and or linear within your organization, is leaving an impression with a patient. And if you do not have people that are interacting with folks and patients in a pre-care setting, in a time of service setting, or even in a post-service setting, that are actually touching your patients, either pre-care or post-care, in an environment that do not like people or do not have the skill set where patient interaction and customer service are a blessing or a high majority skill set within their function, I would encourage you to move them out of those settings, because they are leaving impression within that. And then as we kind of focus through that, the healthcare process as a whole, the individual technologies and settings that we're interacting with are leaving expectations, or I'm sorry, leaving the experiences with us And what we're bringing into this from a patient perspective, and I think we all need to understand this, we do have the benefit of most of us being a patient within our lifetime, or we will be a patient in our future life. But we are not really gauging or understanding that this health system is different than this health system in terms of our expectations of process and interactions. We're gauging that experience off of what our experience is in an online shopping environment. And everybody overuses this example, but the Amazon-like experience. How do we interact with Marriott? How do we interact, with Delta or Southwest? These are the experiences when I think about the patient access, appointment scheduling and availability, the patient financial experience. How are these systems interacting with me from a consumer environment? Because that is the expectation that I deal with on a day-to-day basis that I am then taking into my care setting in terms of my interactions within the clinical experience for those non-clinical touches. That is the experience that then is driving this loyalty. As you put the care quality, the workforce engagement along with the healthcare process together, that is driving whether or not this patient is forming loyalty for you or to you, or is it against you? And when you think about loyalty as what does this matter? Think about it in the sense of, if this patient never walks back in our doors, do we care? Now, in the traditional brick and mortar healthcare environments of large health systems, I don't know that answer has always been yes. When you look at kind of as the healthcare experiences and the delivery continues to provide more linear base, meaning that you're seeing more and more for-profit urgent cares, you're seeing the care delivery extended outside of the traditional enterprises, you're starting to get into these more consumer-like experiences where it's much more like Marriott, where it's much more like Southwest, airline industry, hospitality industry, online user environments. That's the experiences that they're having because they care about that individual consumer, because if they don't capture the attention of that individual consumer from a loyalty perspective, they cannot get enough volume in order to earn what their returns need to be from a business perspective. And so that has had a dynamic shift in terms of whether or not we should care about loyalty. And I would argue, obviously, we need to. When you think about this in terms of the lifetime value of a patient from a self-pay perspective, it's usually around $184,000. If you extend that into their household, it actually shoots up just to right around $405,000. So when you start to do the math, and I'm not a highly intelligent individual, but I can run a calculator, how many of those patients does it take not to come back in your doors before those doors don't even open for anybody? And that, honestly, I believe that anything that we talk about from here on out really needs to be looked at from the lens of that. Meaning, do I care about loyalty? Do I care whether this patient comes back into our facilities and receives care from us moving forward? And I think if you look at it from that lens, then some of this will start to make some sense to you. And hopefully you can provide some education to where you take 2 or 3 items out of this and say, listen, this is not high stakes investment. This is not rebooting our EHR. This is not, going to the board and asking for, a capital investment of X in order to, it takes an act of God in order to move the needle here. These are fundamental technology points and processes that can be thought of and implemented relatively easy in terms of the process. But let's just point out some fragmentations around this process really quickly. And sorry for jumping around. It auto launched there. So when we think about the patient care journey, in terms of what is that first interaction that the patient has within our institution, normally that goes from the price shopping environment, and that's associated to a vendor that then goes to patient messaging in terms of what their care appointments are within that. It goes to the registration process, to access, to intake, to consent and preferences, onto then a post-adjudicated environment in and around that process. And I'm not sure why this keeps flipping ahead, so I apologize on that. But then it goes all the way through the individual touches we had. Now, the association that I'd like to make in terms of this environment is that most of these environments, that maybe 1 or 2 are associated with a single vendor, but generally it is 1 or 2. It is not the breadth of the experience that you can create in terms of a conjoined experience where data is flowing naturally, information that we understand within price shopping or patient messaging is kept in terms of the process of the registration process to then even what the workflow is on the patient access environment. These things are disjointed and fragmented, which then does what? If we have technology that is unable to connect one another together in terms of an extended experience, if that is fragmented, then that experience is going to be fragmented, meaning that I'm going to be filling out one form over here with an expectation from a environment perspective, again, how I interact with all these other environments, to understand how the individual connection is made, meaning that if I fill out a form here, my expectation is that I don't have to fill it out in the next step. And so within this environment, it then creates this fragmented experience because these things, usually speaking, are not connected together. And so therefore, all of the different technology points and all the different vendors that you have associated within this process are leaving the patient in a non-personalized, multiple touch fragmented environment that does not increase the experience and or loyalty. So if we moved ahead in the poll, because this technology really wants us to take this poll because it keeps advancing to this. How many vendors do you use to complete a patient's journey similar to what we just talked about, shown in the previous slide? I'm gonna give about 30 seconds of this, just simply respond, whether it's 1 to 3, 4 to 6, or 7 plus within this environment. We'll give you 20 or 30 seconds to answer this, and then we'll move forward within the process. Okay, about 62% are saying between 1 and 3, 37.5% between 4 and 6, and then really good news is that more than 7, the answer is 0. So at least we're kind of thinking about this in terms of how do we consolidate, not necessarily from a vendor perspective, but how do we consolidate the technology experience to where that extended touch and that extended technology in terms of the environment and the experience and the interaction that we're having with patients has the ability to kind of carry through. And we'll come back to this in a second from an educational standpoint. What we do know in terms of the current technology limitations and potentially even roadblocks within the patient experience is really around the fact that the traditional approach is no longer sustainable. And this is obviously my opinion in the sense of where we see the market. I get the advantage of traveling the country from east to west, north to south, and interacting with a lot of great revenue cycle leaders to understand, number one, what is working in their shop, where they've taken advantages from a technology and a deployment to actually enhance the experience. And what we're seeing is that most of these disparate technologies, whether it's slowed or tiered deployments, disjointed the patient experience, low or no touch point personalization, meaning that we're not creating the individual outcome for each individual patient touch, that this individual message is the same for this patient as it is 50,000 patients, even though we should know more about them. Insufficient labor utilization, low to no scalability, siloed ownership and metrics, meaning that there's not individual correlation in terms of outcomes that we need to have through the individual process, as well as vendor alignment, or in this case, misalignment. These are the things that we hear from folks like yourselves that are joining this call that we have accepted over time. And I think when we look back at historical, it wasn't until this kind of consumerism that is starting to push that, but that consumerism is starting to push because now that payer environment is up to 20% of the overall revenue reimbursement. So, the old sayings that were 3 to 4 years ago in terms of the patient is the new payer, that it's, equal to what, UHC or United Healthcare is providing you in terms of reimbursement, that now they're making up 20% of that. So if we don't care from a loyalty perspective in terms of the patient experience of that patient coming back in our doors, we at least can align it to what the actual metrics from a numbers, from a finance perspective means and why we should care about this environment. Now, if we think about this from that traditional approach no longer works, then we have to assume then a new approach then does make sense. And here's where our interviews with the individual revenue cycle leaders across the country are kind of thinking about this in terms of creating a true linear approach from a patient experience standpoint, meaning that getting patient A to Z in terms of having a coordinated technology all the way through so that the information that we're understanding from a price shopping environment can actually carry through the environment of the sense of pre-care messaging, to patient intake, to consent and preferences, meaning that if I fill out an individual environment or a form within pre-care messaging, can I actually have that already pre-filled out in intake? And if I fill it out in intake, does that consent and preferences then hold true in how the communication is happening at the end? The same as if I'm just starting at pre-care messaging, what is that process then going all the way to how I'm interacting from a payments environment? Do I have card on file in all of these environments to where I am creating this experience for the patients? When you can create a connected patient experience with a single vendor or with a single technology flow, you're empowering the staff of Intelligent Financial Conversations. What does this mean? It means that the information that we're collecting on the front end can be utilized in knowledge around every touch point that we have with patients within that environment. Why? Because they have entered the information in. In the old way, then that was just a point, right? That the patients entered the information and then that information was no longer carried or captured to other touch points. When that information is carried through these additional touch points, that creates a better experience because the patient is not having to redo the information. How many of you have gone to a dentist office or even a doctor, your primary care physician, and you're filling out the exact same paperwork that you fill out multiple times throughout the year, or you just filled it out and then you hand it in and they give you a new form, half of which is from the information that you just filled out? There is a better way in terms of empowering these interactions within patients, but it does take a coordinated technology environment to be able to deliver that. But the most important part here that I really want to impart upon you is once I have that information, how can that information actually empower the conversations that your staff has with that patient instead of asking the same questions, and or it could be a single question that is just to the point of annoyance because the patient has already explained that. Understanding your patient portfolio to understand how should I interact with this patient to be able to understand how and why I need to say the following in order to engineer an outcome for this individual patient. That engineering could be driving self-service adoption. It could be connecting with the patient within a pre-care, so we're informing their post-care journey. It could be mainstreaming the intake process to where I'm trying to remove obstacles and roadblocks into this patient satisfaction. But once I do that, we're telling core elements that can tell a great story from this individual patient where the customer service rep and or the patient access person can have more information at the point of conversation to where they create a better experience. And so when you think about this in terms of putting the patient understanding at the center of the experience, what does that mean? If I'm putting the patient at the center, then that means everything around them in terms of touching or driving an outcome is actually for this patient's best experience. How do I drive that best experience if I have disjointed technologies and I'm not necessarily thinking about the interaction of the patient to the outcome? I'm just thinking about, well, I have this technology. We have 3 systems. It is what it is. I can tell you this from experience, and I do a lot of behavior studies in terms of whether it's user interfaces or behavior modification or behavior science. And within these studies, I find very common themes. The patient, or let's say the consumer, doesn't care about your problems. They really don't. And I want you to hear that. Maybe above anything else, the patient does not care about your complexities. The patient does not care about your issues. They kind of have that impression. It's like my first boss, when I first got out of college, he had this saying, and it was highly annoying at the time, but it really has done me well within my career in terms of taking the proper lens of different situations. And his saying was this: don't let your problem become my problem. And I think that's what the patient experience truly is about when I'm saying they don't care. Don't let your problem become the patient's problem. And that doesn't happen when you put the patient at the center and everything else is working around that center in order to generate an engineered outcome, which is in their very best interest. When I think about this understanding your patient profile, I think it all starts with intelligence. I often make this joke, oftentimes, that when I come home from work and I have a teenage daughter and a teenage son and a almost third teenage son, and if there could just be a message board on the door as I walk in that gives me the disposition of each one of those teenagers, my life would be not marginally improved, it would be significantly improved, to know what kind of landmines I should try to avoid in order to not get into this very feeling-oriented conversations. I guess I'll put it to you that way, and be as respectful to my children as I possibly can. But I think that's a really good analogy in terms of taking that to the patient engagement. Whether it's in our personal lives or whether we think about this in our professional lives, the environment and the interactions that we have with individuals are better, meaning they're more improved when there's information known about that individual. And that is the same thing that is true from a patient interaction. If I'm engaging and activating the modern consumer, think about that in all the technology that you interact with on a daily basis. Think about the best interactions that you have within your consumer environment, whether that's going to a box store and buying merchandise, whether that's going to your grocery store, whether that is going online and buying that, whether you're a loyalty rewards member in terms of certain brands. What do all of those things have in common? The commonality is they're trying to aggregate as much intelligence upon you as actual technology as possible. In order to do what? In order to improve your experience. They want to know that if you are a shopper of vegetables, right? They want to continue to put coupons in your pathway so that you have the opportunity to save dollars in terms of your vegetable buy. And that might seem like a weird experience or a weird example to use in patient experience, but I'm just giving you an environment. Why do you think they're tracking everything that you buy in the grocery store and then offering you cents off of your every gallon of gas and then providing you coupons when it's right about time that you typically buy groceries? Why is it that when you go online as a consumer, you start to see things that you've talked about maybe around your cell phone? We live in a data-rich environment, not to go off on AI and ChatGPT, but the art of perfecting the consumer experience is around getting as much data as you possibly can, and then utilizing that data to remove obstacles and hurdles to create a better experience. And so when we think about patients as a whole, less than 15% of patients will stay with a provider after a poor pre-care or billing experience. That means 85% of patients are saying, see you later. 92% of patient experience is top desired outcome among healthcare leaders. That means of you on this call, 92% of you get it. But when we think about understanding your patient's profiles, it is significant to understand and gain as much intelligence as you possibly can in order to drive a better experience and a better outcome. And this is where we get into this using demographic and behavioral data. This is very common within the industry. And when we think about why use demographic data versus credit-based data, different theories, different philosophies around this, I can tell you where I land, which is not having to go to your board and create policy because you're doing a soft hit within credit. In addition to that is I believe looking at 100% of your patient population is very significant. And I don't feel that not having 10 or 15% of that population that is interacting within the credit shadows, meaning that they're not paying taxes, they're not having banking relationships, they kind of live in the shadows of the credit markets, that you're not going to gauge a very good understanding of that patient. And when you stop and think of whether you're a for-profit or a not-for-profit, especially if you're a not-for-profit, isn't that the exact same population that you actually do need to engage from an intelligence standpoint to potentially drive financial assistance? So that's why I'm really big in terms of demographic. I just think that you have a better scope of understanding 100% of your population, but it doesn't just stop there. Understanding that behavioral data is significant to this process, but one is not necessarily in lieu of the other. These things need to work together in order to drive the very best engagement strategy that you can do that. And so when you think about that, how does that then work? Well, it's about knowing your patient, the know me experience. I usually like to use the analogy of Cheers. When Norm walks in there, there's probably people in this call that don't know that there was a show called Cheers. So I'm sorry that we're older than you. But within that, Norm walks in and everybody knows his name. That is the experience in which we want to have in every setting that we spend money. When I go buy tires, I want to connect with somebody that I actually know. Why? Because it builds trust. There's the sense of trust. There's that loyalty that attaches itself to the trust environment. I want to know anybody that I'm interacting with because it will have a better outcome. So when we know that patient, what are the things that we want to know? We want to understand their consumer behaviors. We want to understand what is their ability to pay, meaning capacity. Can this individual patient afford the balance in total? Or do you need to actually offer them an individual payment plan that is more geared to their capacity? And using your own data in order to drive that predictive analytics in terms of both the demographic and the behavioral. These things are coming together to understand it from a predictive analytics perspective. But then how do you use that? I give the example, if there's someone on this call today that has someone in your health system that has all the intelligence, right? The smartest person in your organization, and let's say they came up with a cure for cancer, let's say that. But if they keep it to themselves, what good is it? What good is it? Is it just good enough to know that I'm really, really smart and I can have the ego and the pride that goes along with that? Or does it actually become beneficial when that knowledge is actually provided? When that knowledge is actually used? When that knowledge is actually used for something that is good? That's where I think about taking the predictive analytics and moving it into precise engagement to where this is us then using, as an industry, using the intelligence to then guide outcomes, to engineering outcomes that are interacting with patients, whether it's print, whether it's text, whether it's email, automated calls or CSR engagements, where it's giving precise engagement, where we're engineering outcomes to drive payment in full, to drive prescribed payment plans, knowing that I understand their capacity to pay is only $150 a month. Then why in the world are you giving them a bill that only states they owe $1,500? You know what they're going to do? Throw it away, or they're going to ignore the text. Engage that patient with the information that you know in order to engineer the outcome that is in their best interest. Why engage with a patient that qualifies under your financial assistance policy, sending them 4 communications, wasting postage, right? Wasting effort when they just simply need to apply for your assistance program. There are smarter, faster payments at a higher yield when we engage patients with intelligence. You're stepping into the world that used to be, or stepping out of the world that used to be, into the world that it is today, in which in every economic situation that you have, meaning every dollar that you spend, they're trying to gain as much information on you as possible to provide a better experience that then kind of narrows the lane in terms of driving you to the very best outcome. Whether that is buying an extra bag of broccoli, whether that is upgrading to a better room, whether that is catching the cheapest flight, or whether it's buying that stupid and more expensive baseball bat for your son. All of these experiences are gathered to say, what do we know about this patient? How should we engage this patient? And how do we provide them an individual outcome that not only is in their best interest, but it actually is in the best interest of the health system as well? That's when things get exciting, folks. When we think about how do we engineer outcomes within the environment that actually is in the patient's best interest. And how many days can you wake up in the morning and say, you know what I do today is actually going to benefit these individual patients, and it will actually benefit the employer in which I work. That's a really good day. So just to take a short break here in terms of taking a poll, are your patients able to make a payment or set up a payment plan based on a presented estimate? So I'm going to take 30 seconds there to go through that. It's either yes, no, or I'm not sure. And that's okay if you don't know. So 40% yes, zero on no, and 60% I don't know. And that's okay. What I would encourage you to do is ask, right? Go ask your director, your VP of patient access to say, listen, are we presenting estimates at time of service to kind of set that expectation around what the individual patient encounter is? How many times in your life outside of healthcare do you go into a situation with a blank check? It's a really tough question, isn't it? Every single time almost in healthcare, up until I would say the last few years. Most of the time we walk into healthcare episodes and we basically are just handing a blank check. Or at least that's the expectation, right? Of patients is that, listen, you're going to walk out with a refrigerator and we're going to bill you later, right? I'm not even going to tell you what it costs, but I have this expectation that you're going to pay me in full. When we think about tying estimates to payments early in the process, the thought process here is a couple things. Number one, setting the proper expectation. Setting the proper expectation that you're about to receive care and there's a fee based on this service. That is really, really important. Having financial discussions within the process to the point where that estimate gives that expectation you're about ready to receive a service. It could be life-affirming care. That's not free. It is free for a portion of our population that qualify for your policies if you have them. But for 85, if not 90% of the population, it is not free. There's an expectation of payment. Within that expectation of payment, let's try to engage the patient on their own terms, whether that's pre-service payments, whether that's engagement where estimations are actually including the actual ability to pay. One of the most funny things very early on within the estimation process was, multiple healthcare institutions out there would turn over an estimate to a patient and then give them no ability to pay. Yeah, I would like to go ahead and pay this today. Oh, I'm sorry, we can't accept your payment. We'll go ahead and bill you once it clears and adjudicates from insurance. Then why? Now, good that we provide an expectation. I think that's really important. But now you got to the point where a patient actually wants to engage. How do we allow that patient to interact? Is the technology there to support that? Is the technology there, maybe not to get the payment in full, but maybe just simply to get a credit card on file, or to get them to commit to saying, listen, here's my credit card. You can bill me up to $400, right? So if the bill is less than $400, just auto pay me, or I'll auto pay within that process. So think about this from a poll standpoint. What percent of your intake process is automated today? A, 0 to 25, the different ranges all the way down. And again, E, if you're not sure, that's okay as well. We'll give about 30 seconds to be able to answer this. %83 unsure. 0 to 25, 16 to 16, almost 17% if we round up. That's relatively telling within our intake process to know as the patients are interacting within your point of service, which is, in my view, this is your first impression upon the patient. And we all know that you can't get the first impression back, right? Once you leave it, you've left it, and that experience is formed. When you think about how we drive the best actual outcomes, it starts within that very first touch with a patient, within that very first process within a patient. How would you prefer to complete forms is a great example. I cannot tell you how many times, and maybe I'm just a little bit odd because this is like a little bit of a lab environment to me. Every time I walk into a care setting, I'm completely analyzing their process and thinking, okay, now you're handing me a paper form and you're asking me to fill out 35 questions. And then I fill all that stuff out, and half of this form that I'm filling out, you actually already know this about me, but yet you're not taking or not using, I should say, the proper technology to make my life better. And it's just lazy, right? And I complete it and I turn it back in. And what do I have? I have grumpiness. Why? Because I don't care about their problems. I care about my experience. So when you think about this in terms of how would you prefer to complete forms, This is just in a survey. 53% digital, online, or mobile application, meaning like I'm in your waiting room. Let me just complete it on my own phone. Why do I have to touch your stuff? Why do I have to fill it out with paper? Why can't I do this at home the night before to where it's already done? Only 25% of patients say hand on paper in the office the day of the appointment. 18% by hand paper home before the appointment. 4% digital, online, or mobile device in the office or day of the appointment. 53%, more than half of your patients are saying digital, online, or mobile application prior to ever walking in your doors. Yet, how many of you do this? More than half of your patients. What is a question that you can ask yourself to say that more than half of your patients believe one thing? That is a statistically significant stat. When we think about that process as a whole, though, what does it mean to actually automate the intake process? What it means is using available technology, such as OCR, to be able to pop an insurance card, to be able to pop a driver's license, to where that information is being taken off of those individual criterias and preloading into the forms environment to be able to do that. Meaning that technology is scanning a piece, your insurance card or your driver's license, and that information is pre-populating screens. Instead of me having to write everything out. Just to prove this point a little bit further, there's a case study that was presented by HFMA a number of years ago, in the sense that at 10 pages of forms per patient, per visit, digitizing saved them, just in the first year alone, $40,000. Patient demographics having been known to be wrong at the time, over 30%. Accurate demographics can reduce bad debt by 4%. Let me give you a finance challenge here. Look up your bad debt placements and take 4% of that number. I highly doubt that there's another initiative that you can take today that would drive a greater impact. Take 4% of your bad debt. Case study by HFMA. No involvement within that study whatsoever. Presenting outstanding balances at point of service increases the chances of 62%, meaning that you're moving money ahead. When I first got in the industry, days outstanding was one of the key metrics within revenue cycle. Was one of the key metrics. And then as time went on, as dollars became cheap, it kind of floated down. I'm really interested over the last 2 years with inflation and interest rates continuing to spike, whether or not days outstanding is going to continue to make a resurgence, right? Come back and be a strong metric within revenue cycle as a whole. I think it will, because the cost of money is really significant. But if I can increase my chances of collecting more than 62%, that is a significant stat in order to improve outcomes. You're verifying insurance is on file, increase your clean claim rate by 22%, completely is allowing you to eliminate rework in the process. And as all of you have labor shortages now, is a very significant process outcome in terms of just using technology in order to automate process. Reported results from a multi-location urgent care with automated intake, data accuracy over 90%. That completely reduces rework. A $4 increase on a per visit environment. You're talking millions of dollars if you apply that to the number of visits within your environment. Reducing front desk staff from 2 or 3 people. You think about this in terms of each care setting that you have and how many front patient access people do you have to arrive that individual patient. Reducing that down to single employees, being able to facilitate all of the interactions within your patients. These are all great outcomes for you, but how does it enhance the experience to the patient? Because you have a known experience to them, you're automating the processes, and you're not asking a question that you already know the answer to. If you ask a question and require the patient to answer it that you already know, that is not having the patient at the center of the experience. That's just, I mean, this is recorded, but I'm just going to say it. Quite frankly, with the technology that's out there today, it's just lazy. It's lazy because it really shows that we don't care enough to change that experience to the patient. And I know that's very opinionated, but I believe it's true because there's so much technology out there that allows you not to ask questions that you already know the answers to if you just had a conjoined experience, right? From a technology standpoint. If we're thinking about that and taking it to the next step, it's really around connecting the patient's pre-care environment to their post-care journey. So if I understand things at time of care or even pre-care, am I carrying those known factors into a post-care adjudicated environment? But before we stop and kind of finish on that side, the percent of your technology used in patient intake and engagement in pre-service is the same for the vendor you use in the post-care, meaning are you using the same technology on the front end from a relationship or a partnership standpoint as you are on the back end? And here's your options, A to E. And if you don't know, that's okay. Just like the other questions, it's an acceptable answer. Give it 20 seconds or so to answer that. Right around just a little less than half, 33%, are saying that you are connected, where the majority, or high 2/3, are saying that we're not sure. It would be a great thing to understand in terms of that setting. When we make the connection from a pre-care to a post-care environment, we're thinking about things that we get at pre-care, whether it's card on file, and how that has the ability to create a faster and more convenient payment experience on the post-care environment or post-adjudication. Meaning that I already have the card on file, so I don't need to send a statement. I don't need you to tell me your credit card information. I just send you a text and say you owe $400. Would you like to pay? I send you a text that says you owe $50. Would you like to pay? And you say yes, pay now. Estimates, setting expectations, and the patients are prepared for these balances in a post-care environment. The intelligence that we know in the front environment are then carried through to know that the exact same touch and the exact same outcomes are presented to that patient in a pre and a post-care environment are consistent. How intelligent is it of you to have intelligence and then not use intelligence? That happens daily. It happens daily, where the companies and institutions spend hundreds of thousands of dollars, if not millions of dollars, on intelligence, but then they don't give it to their actual employees to empower their conversations. Digital assets, meaning if we're gaining consent on the front end and we're not using those digital assets such as cell phones or email addresses along with the consent to then send digital communications because it is their preference on the back end, what good was it to collect it? When we think about engineering outcomes in the sense of creating self-pay outcomes, how do we want to engage the individual patient in understanding that the scoring, the segmentation then matches with the personalized messaging and offers that then drives the right fit for each individual patient? To say, no, you know what, you have the capacity of $160 a month, so therefore here's a payment plan of 12 months that we know with a high degree of probability that you can afford this. That is different than sending this patient, you owe $1,800. Because if you send them a patient, the statement or the communication that says you $1,800 and they don't have the capacity to pay, what do you think the high probability rate is that they actually engage you? Don't fool yourself on that. Percent of patients who opt in to paperless billing today, in terms of just your percentage of your patient population, 0 to 20, 21 to 30, 31 to 40, more than 40%, and again, not sure. Oh, I might have skipped ahead to that too much. I apologize for that. How would they prefer to receive statements and bills today? This is just kind of a breakdown in terms of patient study that we have done. When you think about the individual age buckets, which, you know, age is certainly a determining factor, but it's not always. I can tell you that the percentage of patients that receive digital assets, meaning that, 25% of the patients that are not opting into print and mail greater than 65, that's a pretty sizable number. So don't just say, hey, because the elderly population, they only want to receive paper. That's not true. Patients that trust their provider communicate with me using my communications, they strongly agree that that is important. So 35% somewhat agree. Those are statistically important stats. The ability for a patient to adopt a digital first approach using the very best channels, making them work together to drive the very best practices, that is driven from knowledge. So this is a point to not only know what the outcome should be in being able to know that information, to then generate a communication that then provides or drives or engineers what that outcome should be, but it also needs to be delivered in the method that the patient actually wants it. I can tell you right now, I am not going to answer the 9 text messages that I've received since doing this webinar today, but I really want to. So if that's the case for me, what do you think the best way for my doctor to interact with me that I owe a $50 environment is? To send me a text and my ability to communicate through that text versus sending me a statement. It also produces better results from a digital first perspective. Reach your patients 90% effective within digital outreach. They pay faster, almost 7 days faster. 20 to 30% reduction in postage. Do me another favor on a finance exercise. Your homework is to go look at your bad debt and look at 4% of that and know that you can impact that, right? Look at your postage expense and know that you can at least impact, at the very least, a third. Low opt-out rates, less than 0%. Patients want these experiences. Why? Because it's already their experience in other consumer environments. Utilizing intelligence to drive the right outcome, in my view, is one of the most significant impacts that you can make within your population, but it also can allow you to drive behavioral options as well, meaning that if you're using the technology to say, listen, this patient might pay us right now if we offer a discount within that environment, you are starting to get into behavioral discounting and saying, listen, if we drive self-service and we do it today, maybe we should give this patient a discount if they can execute. Only having the intelligence to be able to engineer that very best outcome, to know whether this patient can pay in full, whether this patient has a low capacity and we need to offer them a payment plan, or this patient qualifies for financial assistance, significantly matters in terms of how you engage with the individual patient. If I pay sooner when presented with the best payment option that fits my ability to pay, 36% of respondents within our survey say, I strongly agree to that. I'm sorry, I somewhat agree. 35% completely agree, 25% being neutral. 35% of your population is saying, I agree that I will execute if you are offering me the best option. When you think about self-servicing rates in terms of all of the payments that come into your institution, if you can eliminate 35% of your call center today, is that a good outcome for you? Does that increase your hold times? Does that increase your abandonment rates? Does the opposite, right? If I can increase patient self-service rates by 35% in terms of how I engage patients and how I'm engineering outcomes, not only does that have a dramatic impact within your revenue cycle, it is actually allowing the patient to interact with your institution the way that they want to. It also has the ability to increase your patient payment rate, somewhere between 1.24 and 1.55. Another math exercise for you from a finance standpoint. Know what your total billings are by a year, and then take 1.5% of that and see if that's a number that drives urgency within your revenue cycle. My guess is that there's not too many decisions out there that you can make that has that type of financial impact today. E-bill adoption, 2.5% increase if we're providing that environment. And here's where I want to kind of end today's discussion in terms of empowering intelligent conversations within healthcare. Again, this gets back to, is it good enough just to know? Is it good enough just to be smart? Is it good enough to be intelligent? Or do I actually have to utilize that intelligence in order for it to be actually good? And in most institutions, we are not providing those outcomes for our staff. We might invest in the technology, we might invest in the intelligence, but we're not allowing our staff to use that intelligence to empower their actual conversations. What do I mean by that? It means that a patient that qualifies for your financial assistance, but you're not telling your CSR rep that, or you're not telling your partner that you're paying to work as an outsourced call center for you, you're not telling them that. They're on the phone to the patient trying to grind them out for a payment in full. That doesn't make sense. Allow the intelligence to empower these conversations. Do you know in most consumer environments, in a call center environment, more than 85% of their call environment is scripted? You know what it is in healthcare? Less than 5. This is a step in the right direction in giving your staff the ability of markers of scripting in terms of saying, listen, here's the very best outcome for this individual encounter, drive to it. Is it a payment in full and most of your staff is slipping to a payment plan? That is not a good outcome financially for your organization. The same as grinding out a patient who qualifies for financial assistance to a payment in full is not a good outcome for the patient, nor for your environment, right? Allow them to use the technology to lever that intelligence to guide their experiences, right? To allow them to guide those experiences where your staff is infusing empathy within the process because like they have that message board right there before they walk in the house. Teenage daughter, not a great day. Don't engage until she engages, right? If I could just have that on my door, my life is markedly improved. In terms of deviceless payments, and this is just additional technology, I'm going to kind of skip over some of this stuff and we'll get to questions, but understand that patients don't always want to interact within things. There's also different technologies out there that are providing a more consistent and coordinated experience for your individual patients all the way through the process so that there's not these disconjointed and fragmented environments to where what I put into one form is not kept into the next 3 to 4 experiences that I have with this institution. And if I can leave you within one thing, engineering outcomes and providing better experiences for patients is absolutely necessary as we move forward into the next iteration of patient engagement, where experiences are only going to continue to get more and more important in terms of whether these patients walk back in our door or they go down the street to the for-profit that is focused in on consumerism. Thank you so much. We'll take some questions.
Thank you for that fantastic presentation, Casey. I know I sure learned a lot, and I'll echo some of the comments that came in, which is we're going to have to watch this again because there was just so much good information there. We do have a number of questions that have come through the chat, and we will try to get to as many as we can in the time we have left, but we may not be able to answer them all. With that said, the first question we have here is, where are we on being able to have information follow a patient through provider and payer changes?
Yeah, I'm sorry, just repeat that question one more time.
No problem. Where are we on being able to have information follow a patient through provider and payer changes?
Yeah, that's a great point. And really what that is like where this information is coming in and how are we updating that from a technology perspective to, again, not have to ask the questions that we should already know. That process is already within from an automated engagement from a pre-service to where as those patients' eligibility situations change, that data is automatically uploaded. So we continue to follow that patient throughout the process. In terms of the market, for instance, to be able to ask maybe a confirming question, not a new question in terms of, has your insurance changed? Again, that's a question you should already know. Thank you.
Perfect. The next question I have here is, what about the Medicaid population?
You know, that's an interesting question because we were actually doing a study with our analytics group, and within that, we started to uncover within one healthcare institution to where, based on an individual criteria, we were kind of found this segment who didn't make a lot of sense in terms of they weren't interacting yet, you know, they weren't engaging, and so what we found is that they actually needed to be engaged from a Medicare environment. So from an intelligence perspective, what we should be able to be identified, again, if we're engaging correctly, we should be able to engage individual populations from a Medicare perspective that might not have skipped the screening process or not identified in the screening process that, you know, unfortunately has made its way into a post-adjudicated environment, and we're still trying to grind out dollars from those environments when they really just need to be re-engaged and re-qualified from a Medicaid perspective. So what I mean by that, answering that question is that how are we utilizing the intelligence to engage that specific population or that specific payer group or type in order to change that outcome? So the thought is that can we hit them on an engagement of a QR code to where they can go right into the application or the enrollment process? Can we hand them a text or a link that they can go in and be able to fill that out? But it is, how do we utilize that intelligence to then understand what is possible, and then how do we create engagement that engineers that outcome. So specifically for that group, it's really funny that you would ask that, because we just spoke about that use case last week. And you're talking about big dollars, right? In terms of being able to reclass that.
Well, thank you for that. It looks like that is all the time we have for today, but I just want to say thank you again to Casey for being here with us and giving this wonderful presentation, as well as a special thank you to Rev Spring for sponsoring today's webinar. Don't hesitate to reach out if you have any questions. Again, this recording will be available to you using the same link you used today to access this webinar live. Thank you for joining us. We hope you have a wonderful day, and we hope to see you again at a future Becker's webinar.
Thank you.